He's a senior consultant with 20 years experience working as in KIMS. Is a well-known laryngologist who has done his DLO, DNB, MS, FRCS in Glasgow. He was the founder, president of Association of Phonosurgeons of India, and he worked as a vice president and past president of the association. We thank you all who have joined today. Today's session will be moderated by Dr. Dushyant. He's also a fellow in laryngology from Pune. Sir, I hand over the screen to you, sir.
Good evening, all. I am Dr. Jaykumar, as a laryngologist working in Trivandrum. As of now, I don't work in KIMS. That's one clarification I want to make. I have got my own group of Jaykumar's laryngology group, and I provide service in the different hospitals, both in Trivandrum as well as in Cochin. And I was the founder, vice president, and the past president of the Association of Phonosurgeons of India. Thank you for giving this opportunity. So I thought we will go to very basic topic, laryngoscopy. You know that everybody know how to do a laryngoscopy, whether it is with an indirect laryngoscopy, that's with a laryngeal mirror, or a flexible or a rigid laryngoscope. And most of the time, the findings are quite obvious. But sometimes, the finding may be a little bit subtle, and unless you are trained for that, you will not be able. So this lecture is aimed at making you comfortable and competent in interpreting the finding, especially for the younger colleagues. Some of you might have already heard this talk, but of course, as is my practice, I'll just modify it a little bit more, maybe a few more slides will be there. So I'm sure that vast majority know who is this gentleman in the picture. This is Manuel Garcia, who was actually a singer come voice trainer, and who is the first human being to see a vibrating vocal cord. He's using his own ingenious technique. Now, visualizing the larynx, you can use the laryngeal mirror. So the main advantage is that the color probably is the best with this laryngeal mirror. The color match, no other scope gives that thing, but all other points are probably negative. Only a fleeting view, no magnification, and it is not possible in everybody. So it is, I think it is gradually fading out, especially in a laryngology practice, where a center where there is laryngology referrals are plenty. I don't think laryngeal mirror has got much role. But it is a great idea to learn the technique, because when you do the rigid laryngoscopy, stroboscopy, you need to know the technique. So that is all about the rigid, the laryngeal mirror. Now the main two scopes we use are the rigid scope. They are ideally suited for the the structural lesions, because most of them are much bigger scope, like the 10 millimeter diameter scope that gives a brilliant quality and clarity of the picture, while the flexible laryngoscope is easy to do. It can be done even in a young child, and they are generally indicated for neurolaryngologic disorders as well as muscle tension disorder. Means when there is not much of structural lesion, but you need to identify the movement of the vocal cord, subtle changes, they all are better picked up with the flexible scope. You know that the rigid scope you are doing in an unphysiological position. You are actually holding on to the tongue, so that it's a little bit unphysiological position. Sometimes you may get false findings. Rigid scope, you can use both 90 degree and 70 degree. Probably the convenient will be a 70 degree, the second one. That's more comfortable for the angle rather than the 90 degree. You can have the 10 millimeter big scope, which gives excellent picture quality. You can even use a 4 millimeter scope. Suppose you don't have a laryngoscope, but you are a practicing rhinologist, you got a good 70 degree scope. You can actually use that scope to get a good picture. Now we'll come to, so with that brief introduction, of course, flexible laryngoscopy, there are two types: the conventional flexible laryngoscope and the chip on tip. Chip on tip is a far more expensive scope, but it gives great quality. It's almost as good as the rigid scope quality, so that is great. So now we will go to the topic proper. Some of them are very, very obvious lesion. I don't think I need to tell you this is the finding and very obvious. So you can see the vocal nodule there. But there is something unusual about this vocal nodule here. I think you might have noted that, because this is not only an asymmetric nodule but also a asynchronous nodule. I suppose you can appreciate that, because the right vocal nodule is at a posterior level, left vocal cord is at an anterior level. So this can actually happen sometimes. So we actually don't know why it happens. We will come to that point a little later. So some of them are very, very obvious. So vocal nodule. Vocal cord polyps, again, no need to, but one thing I wanted to tell is that when I have seen sometimes youngsters making a diagnosis of unilateral vocal nodule, that's not really correct. Vocal nodule never comes alone. It's a callosity, so it has to be bilateral. It may be asymmetrical, it may be asynchronous. Sometimes you may have to look very, very carefully to see the other nodule, but it won't come just in alone. While vocal cord polyp is usually unilateral, it happens only on one side. Of course, you can get bilateral, but generally it will be something like this. You can see that there is a medium-sized vocal cord polyp on the left side. Otherwise, everything is fairly okay. You can see the polyp, the nodule, and the right side, and the vocal cord, the vocal process. This is again, I just want to highlight. Sometimes people get confused with this finding. This is the vocal process. So sometimes vocal process may be very, very, very prominent. So many times people can actually mistake it as a lesion. It's not. Vocal cord cyst, again, a very unlike polyp, it will be very smooth, spindle shape or circular, and characteristically, the strobe will not show any mucosal wave over it. That's a typical finding. You can see that there is on the left vocal cord. There is a cyst, but hardly any mucosal wave. Again, sometimes youngsters might think that there is no mucosal wave because the cyst doesn't vibrate. It is not. Everything in this universe vibrates. Vocal cyst also vibrate. The problem is that stroboscopy is an illusion, optical illusion. So it's actually based on the frequency of the vocal cord proper. Cyst also is vibrating, but at much different vibrating frequency, so that the strobe effect will not pick up the vibration. Otherwise, strobe also is vibrating, strobe, humor, everything will vibrate. But stroboscopy is based on the principle or on the vibrating frequency of the vocal cord proper. So it will pick up only the vibration. Yeah. So that was about the Laryngis edema. And of course, papilloma is again a fairly common condition.
Can you restart from vocal cord cyst? We have missed from there.
Oh, really? Right. Okay. So this is the vocal cord cyst. You can see that on the left, spindle-shaped mass with no mucosal wave at all. Are you hearing me now?
Yes,
sir, we can hear you.
Go ahead, sir.
Okay. So you can see the mucosa. There is that in the cyst there is hardly any mucosal wave at all. There is no mucosal wave now. You can see that. That is because the cyst vibrate at a different frequency from that of the vocal cord or the Laryngis space. It is not that the cyst doesn't vibrate at all. Everything in this universe vibrates. But strobe will pick up only the vibration of a frequency which is similar to the vocal cord range space. That is why you get the impression that the vocal cord, the cyst is not vibrating or the growth is not vibrating. This is the Range's edema. Again, a very common condition. You can see here now, fairly massive Range's edema. That's a grade 2 edema. Grade 3, there will be even obstruction of the airway. You are getting the picture now? Hello?
Yes, sir, we are getting, sir. You can go ahead.
Okay, if there is any problem, let me know. Now,
Okay.
that's the grade 2 Range's edema. That is more common with the smoking. Of course, you have to rule out hypothyroidism and, of course, severe LPRD2. Papilloma, again, very telltale diagnosis. No need to teach any one of you to tell that this is papilloma. Every one of you know, I am sure that. So that is a bosilated, multiple pedungulated or sessile mass involving the entire left vocal cord. So that's a classical papilloma look. Again, very straightforward diagnosis. Most of the time you can actually diagnose it very, very clearly. Not much of a problem at all. Malignancy, again, most of the time very definitive finding, irregular mass with the restricted mobility of the vocal cord, hardly any mucosal. So they all are very fairly straightforward diagnosis. You don't need to think too much about the diagnosis. Of course, occasionally you may make a wrong diagnosis. Histopathologically, it may be proved different, but most of the time we can diagnose. Now, web again doesn't need too much of experience to diagnose that. You can see that the web is there between the almost the whole half of the anterior half of the vocal cord is actually have a web connecting each other. The only thing you have to look in a web is that whether it is a thick web or a thin web. Thick web usually may be associated with a subglottic stenosis. So be careful. In that cases, before you operate, you always go for the CT scan. Sulcus, of course, now it is everybody knows, but you know, when I came back from Ireland at that time, when the phonosurgery was in the beginning, only few of us were doing. So at that time, the awareness of sulcus was not there, but now I am sure that every one of you know what is actually sulcus is. Most of the time, vast majority of the time, it is actually a congenital condition. You can see that on the medial surface of the vocal cord, the groove-like structure, that's a sulcus, and it produces hardly any reduced mucosal wave. All this typical, you can see that the mucosal waves are very, very minimum. The middle segment hardly has got any mucosal wave at all. So that is typical of sulcus. Unless you look for it, unless you are familiar with this condition, sulcus vocalis, you won't be diagnosed. That is an issue. So awareness of the sulcus vocalis has gone up over the last few years. I'm happy that now most of the ENT surgeons are familiar with the sulcus vocalis. Vocal process granuloma. Again, this people many times make a diagnosis of vocal cord polyp, and once they excise it, when they come back, they become very nervous, thinking that it is malignant. But if you know a vocal process granuloma, then you know that that's the behavior rather than anything abnormal about it. So you can see that vocal process granuloma on the right side here. Again, the position can vary. Sometimes it may be a little more posterior. Sometimes it may be on the medial surface of the body of the retinol. All these things can happen. So most of the time, what happens is that you will not get a polyp or a nodule or a cyst at the vocal process or behind it. And luckily, usually malignancy is a rare condition here either. So usually the first diagnosis here should be a vocal process granuloma. But when you excise it and when it comes back many times, people get worried or they think that it may be malignant. Histopathology also might tell that there are some suspicious cells. But vocal process granuloma routinely recur unless you treat the basic cause. That is a mild grade perichondritis. So you may have to treat with Botox or something like that. LPRD is a very overdiagnosed condition. Even by myself, I know that, I accept that, but some of them are very classical signs. This is a severe interarytenoid pachydermia, almost look like a vocal cord polyp. You can see that irregular, huge one. So this is again nothing to worry about. No tumor generally happens there. So this is an interarytenoid pachydermia, one of the most definitive signs of laryngopharyngeal reflux disorder. So that is fairly a very common condition, but sometimes really overdiagnosed when we don't have any other diagnosis, and when patient has got a vague symptom, many of us actually even presumptively give treatment for laryngopharyngeal reflux disorder.
Hello, sir.
Submucosal hemorrhage.
Hello.
Yeah.
So there is a small request from 2 to 3 members that telling you to just tell the treatment for every condition in brief, if possible. Just 1 line or 2 line.
Okay. Okay.
Yes.
Okay. So this is the obvious case, that the submucosal hemorrhage. You don't require any actually treatment, active treatment. You can actually give absolute voice rest, and this is one condition. If a singer comes with you have to tell you that you can the program. This is not a good condition. All other conditions we will allow them to sing with some medication, but when there is a hemorrhage, it is better not to sing. That's very important. So submucosal hemorrhage is one of the major indications for an absolute voice rest. Nowadays, we advise absolute voice rest very rarely. This is one of the indications. Of course, you can give enzymatic preparation for absorption and all, but generally the main treatment is voice rest. Capillary ectasia is something like a varicose vein. Sometimes you see this finding. You can see that very prominent blood vessel on the left side on the superior surface. You can even see a very prominent capillary hemangioma-like thing. Usually they don't produce any problem. But the problem is that if the person has the habit of shouting, one of them may burst and result in a submucosal hemorrhage, and if untreated can go on to become a vocal cord polyp. Usually this is being on the superior surface of the vocal cord. It doesn't produce much of a voice problem. If it is producing problem, of course, you can actually use carbon dioxide laser to just vaporize it. If you don't have a laser, what you can do is that you can cut with a finer instrument, you can transect across the longitudinal axis of the vessel so that you disrupt it. You can also inject steroid and hyaluronic acid there. This is a classical case of tuberculous laryngitis. We were taught, when the laryngoscope was not there, we were taught that, the classical sign is a monochorditis. So here you can see that the right vocal cord is perfectly normal. Left under magnification and stroboscopy, you can see that actually it is not just a congestion. It is an irregular reddish mass with hardly any mucosal wave. So that's a tuberculous laryngitis. Of course, you need a tissue diagnosis or other corroborative diagnosis. It is not uncommon to have a isolated laryngeal tuberculosis, but still, whenever you suspect a laryngeal tuberculosis, you have to investigate the pulmonary part with your pulmonary colleague, and if there is obviously that evidence is there, then you need not take a biopsy. You can actually proceed, unless, of course, you have got a very strong suspicion of a coexistent malignancy. Amyloidosis is not a rare condition, but not a very common condition either. So in over last 20 years, I have 21 cases. So that means in a referral center, you get at least one case in a year. It can present in different conditions. Usually it is very smooth, and usually it has got an yellowish tinge. So these two things, you should arouse the possibility of amyloidosis. It can occur in the supraglottis. It can occur rarely in the glottis. It can occur in the subglottis. So, but in supraglottis is more common. So you can see that picture. It is a very smooth surface, unlike a conventional polyp or a cyst. And you can see that slight yellowish tinge is there. That's a typical finding. You can another case here. Again, you look carefully, that yellowish tinge is there. That is almost typical. And it's very important that when you suspect amyloidosis, you have to write in the histopathology request, rule out laryngeal amyloidosis. Otherwise, pathologists might not do that study. So always have a high index of suspicion. It's not a rare condition. It's not a common condition either, but it can occur. So any atypical, smooth, yellowish mass anywhere in the larynx, you should think about amyloidosis. It can, of course, affect other areas also, nasopharynx, oropharynx, but usually laryngeal amyloidosis is isolated. Rhinospodios is not very common. It is fairly common in Kerala, but even in Kerala, it is nowadays very rare, and occasionally you can get a laryngeal rhinospodios. This is a very rare case here. Extensive laryngeal rhinospodiosis patient presented with stridor. We had great difficulty in intubating. We can see that from the laryngeal introitus, the mass is coming out, huge mass. That's a massive rhinospodium. It's not a very common condition, I will say. Occasionally, you can get rare condition. This is a granular cell tumor, young lady. Of course, I didn't diagnose this was a granular cell tumor. That is very rare thing. I actually suspected a amyloidosis here, but no, I am presenting this because you can get this kind of conditions also. This is the granular cell tumor in a very young lady. It's a benign condition. If you do exercise completely under follow, she's fine now. This size surgery I did when she was 12. Now she's 22. She's fine. Nothing major. Sarcoidosis, again, if you are not familiar with the finding, you may miss it. This is almost the typical telltale sign of sarcoidosis. The huge tire-like, it looks like a tire of a car. The epiglottis is the most commonly involved structure. You can see the supraglottis. The whole supraglottis is involved. Massive epiglottis here, huge. So this is almost a typical sign of sarcoidosis. You can see the vocal cord is normal. You need a tissue diagnosis. You can treat medically with the physician if it is symptom producing. The surgery role is that if it is creating. This patient had actually didn't have any stridor, but the problem was that patient was having sleep apnea and CPAP was not working. So in that case, you can actually debulk the epiglottis. You can do a partial epiglottomy, or somebody has described a surgery known as pepper pot epiglottoplasty. Means just like the pepper pot, create multiple holes in the epiglottis with either with the cobblator or with the laser. So create lot of holes through and through from the lingual surface to the laryngeal surface. So what will happen that you are debulking it, and when it heals, because of the fibrosis, it will come down. You may have to repeat that surgery later. Presbylarynx, now we diagnose it more and more common now. You know that the typical finding here, the vocal process is more prominent. This is what I was telling. So when the vocal cord as such is wasted, the vocal process will become prominent. Don't make the diagnosis of a posterior based vocal cord nodule or something like that. So that is typical of a vocal sulcus. You can see that a huge ventricle that also suggests there is a vocal cord atrophy. Now, coming to the major role of flexible laryngoscopy, of course, there are two scopes. This is a conventional, less expensive, but the clarity may not be very great. But you have got now the chip-on-tip, which is a far superior quality, but obviously more expensive. But if you can buy a chip-on-tip, maybe you can even avoid buying a rigid scope, because if chip-on-tip gives the function of both. Means both the flexible laryngoscope as well as a rigid laryngoscope, because so quality is better and you can assess it physiologically. For all neurolaryngological condition, it is better to do with a flexible laryngoscopy. So bilateral vocal cord palsy, unilateral vocal cord palsy, vocal cord paresis, tremor, adductor spasmodic dysphonia, abductor spasmodic, all are better diagnosed with a flexible. This is a bilateral cord palsy, so hardly any space. So this kind of patient will obviously require airway securing depending upon the cause. Some of them might recover, say, post-thyroidectomy. If it's a neuropraxia, you are not going to do a definitive procedure. You need to secure the airway. You may have to do a tracheostomy, or else if you want to avoid a tracheostomy, you can do suture codopexy, a lot of other options. If it is a persistent bilateral cord palsy, there are series of operations, but the most commonly performed will be a Kashima's posterior cordotomy. Of course, newer operations like the bilateral selective laryngeal reinnervation is coming. Unilateral vocal cord palsy is not an emergency, but they produce voice problem. See that, you can see that. So the left cord is paralyzed here, right is moving well. But it is fairly a compensated unilateral vocal cord palsy. So patient's voice is not very bad. May not require much surgery, but if it is not medialized properly, you may have to do some sort of medialization. There are temporary procedures like injection laryngoplasty or permanent procedures like medialization, thyroplasty, or thyroid rotation. Now, the condition is now being diagnosed more and more. We didn't know about vocal cord paresis that much few years back. Now we know that it is quite possible to have vocal cord paresis. Sometimes they can be very, very subtle. Unless you look for specific point, you will not diagnose it. So that is why this slide is important. So this is a unilateral vocal cord paresis. This is not that subtle. You can still see the left vocal cord is paresis. But sometimes you will not get even this finding. But what is the clinching point? The most important point is that in a vocal cord paresis, the affected side arytenoid will actually cross over the midline. It may look like a paradox. It is not. In a paresis, so this is a left vocal cord paresis. You can see the left arytenoid has gone over the midline to the right side. This is because of the unopposed, the intra-arytenoid has got bilateral nerve supply. So intra-arytenoid is intact. So what it will do? So it is between two arytenoids, like a tug of war. The right arytenoid is very healthy. So it will stay back. It is like it has got a very good foothold. The left arytenoid, which is paralyzed or paresis, doesn't have a foothold. So with the result that the affected arytenoid will be pulled to the normal side. So don't think that this is actually compensating the left arytenoid. It is actually a left vocal cord paresis. So this is one of the most important signs. In a vocal cord paresis, there will be phonetrachea. The arytenoid will be, the affected arytenoid will be pulled across the midline to the normal side. And sometimes you can, here also you can see that the ventricle will be much more prominent on the affected side because there is a vocal cord paresis, the muscle wasting is there. So that is an important sign. Vocal cord paresis is now being more and more diagnosed frequently, and even one doctor told that now it is becoming the LPRD. That means you are over-diagnosing, but certainly there is a lot of cases of vocal cord paresis. Usually they recover, the management is neurotropic agents, voice therapy. Of course, if it is persisting over more than 2 weeks, you have to do, some people will wait up to 6 weeks, you have to do a CT examination of the neck to rule out the pathology. Occasionally, you get a very rare condition known as the interarytenoid paralysis, a very rare condition. You can see that normally the arytenoid, there is a gap, and when you speak, they close it. Here, you can see the keyhole-shaped phonatory gap, and the arytenoid never come closer to each other. You can see that. So that is a very, you see that that's a classical keyhole-shaped phonatory gap, and you can see that the cuneiform cartilage, the coniculate over the arytenoid, but between the arytenoid there is a big gap. That means the arytenoid, the interarytenoid is not pulling it medially. One of the most difficult conditions to treat. You can't actually do that. If you fix that, then patient will have stridor. You can maybe fix one side, but even that is unjustified because it is a mobile vocal cord. It is a very, very difficult condition to get a satisfactory result. Superior laryngeal palsy is one of the most difficult conditions to diagnose. Isolated may be easy, bilateral is very difficult, paresis is extremely difficult. There are many signs described, none of them are very convincing signs. Bowing is probably a sign, and so is the relatively transverse aryepiglottic fold. But this itself is controversial. So if there is a bowing of the vocal cord with a transverse aryepiglottic fold, you can actually diagnose, especially with a history of thyroid surgery. You can also get a post-viral superior laryngeal palsy. But the definitive diagnosis will be only by doing a laryngeal EMG, cricothyroid EMG, under ultrasound control. You have to make sure that your needle is in the cricothyroid. For that, you have to use ultrasound. Make sure that it sits in the cricothyroid and do the laryngeal EMG. Myasthenia gravis is not a very common condition. Again, not a rare condition either. Luckily, it actually produces more of an adduction paralysis than an abduction paralysis. Again, laryngoscopy alone will not be the diagnostic point. You have to have the history of myasthenia gravis, and of course, if the finding is something similar to that, there is a vocal cord and adduction is incomplete, you can see there is some amount of penetration, then it's actually a diagnosis. So just by looking at the vocal cord, you can make a diagnosis that this is a vocal cord paresis. Myasthenia gravis. You are hearing the video? Hello?
Yes, sir. We can hear you.
Now, abductor spasmodic dysphonia usually is diagnosed by the typical abductor spasm in the voice, but in the laryngoscopy also you can see the abductor spasm. Sorry, this is adductor spasmodic dysphonia and abductor. So you could see that the adductor spasm with some tremor also. Vocal cords are structurally normal. So corresponding to the adductor spasm of the voice, you can see the vocal cords are going into spasm. Many times there will be some overlapping of that is adductor spasm. Of course, the treatment is Botox into the vocal cord, or you have got a few surgeries, type 2 thyroplasties, thyroarytenoid myoneurectomy, endoscopic as well as external denervation. My preferred surgery is the external thyroarytenoid myoneurectomy that is done under local anesthesia. You can cut the thyroarytenoid muscle and cut the nerve to it. Abductor spasmodic dysphonia, classically there will be that flaring of the ala nasa, but also you will have the abductor spasm on the video. Each time patients speak, you can see that there is the gap there. That's a classical abductor spasm there. Vocal tremor, usually associated with the essential tremor too. You can see that the whole larynx is very tremulous. So this is different from adductor spasmodic dysphonia. Though adductor spasmodic dysphonia and vocal tremor can occur together, this is classically tremor alone. Watch, the entire larynx is shaking. Usually the treatment is medical. With the neurological surgery, it's unlikely to improve. Now coming to the muscle tension dysphonia. which is very, very common. Of course, you should know what is normal. As of now, the definition of a normal vocal cord function is highly inadequate, insufficient, I feel. It needs to be corrected. We are working on that. But generally, the accepted parameters is that one is that there shouldn't be any phonatory gap. There shouldn't be any supraglottic phenomena. That means the ventricular band shouldn't come, arytenoid should come anteriorly, and aryepiglottic fold should have a pointed arch. So you can see that's a normal phoneme. So these are the criteria for a normal vocal function. Now, you already saw the vocal nodule. Next is the ventricular band dysphonia. Here you can see that when patient is actually a singer, the ventricular band actually adducts too much. Watch the ventricular band now. You can see that huge adduction of the ventricular band. You can't actually see the vocal cord at all. It's a classical ventricular band dysphonia. The treatment will be, of course, voice therapy. There are a lot of voice therapy techniques, but if it is a very resistant case, you can actually do coblate resisted ventricular band excision, which gives fairly good results. And another common, it's not that common as ventricular band, it's an anteroposterior compression where the arytenoid come closer to the epiglottis each time patient phonate. So this is the arytenoid coming closer to the epiglottis here each time. This happens in people who tend to speak at a much lower pitch than what is their ideal pitch. Of course, puberphonia is a common condition, especially in Kerala. So they will have a very high pitch phonation, but also you can see that there is a phonatory gap. I'm getting the message raising the hand. Is that a question? Somebody is asking.
Yes, I'm just writing all the questions. You can continue the presentation.
Great, great. Okay, so in puberphonia, you get a falsetto mode of voice production. You can see that vocal cords are normal, but there is a persistent phonatory gap, parallel phonatory gap. And sometimes, especially in singers, you get another finding known as the pharyngeal squeeze. When the pharynx, piriform fossa squeeze, normally for good voice, piriform fossa should be very open, should be free. But here, when she is singing, you can see that the pharynx squeeze too much. When she's singing high pitch, watch it. You saw that the pharynx squeezed. This is the squeezing of the pharynx. It is touching the medial wall. It shouldn't happen. That's not normal. So that obviously requires voice therapy. That's a wrong technique. Now, come to the last few slides. This is new addition to the study of the larynx. We all tell that larynx is symmetrical. How symmetrical is larynx? Anatomically, it's almost always symmetrical, but physiologically, it is other way around. Asymmetry is the rule rather than the exception. How come that happened? We don't know really. The right and left work sometimes differently. That is how. So if you look at the arytenoid, many times you get valid points. So even though it is a very symmetrical organ, it produces many times asymmetry, and it keep on varying in pathology and in normal conditions. There is a study saying that overriding arytenoid occurring 10 to 15% of cases. That was the study when we were students. Now they have gone up to 60, but I will say that it is actually more than 80%. Most of the larynx is asymmetric. Now, how you look at it? You still the picture at the adduction and watch 2-3 points. One is the interarytenoid axis. You can see this is the interarytenoid axis and see the interglottic axis. Normally, when it is a symmetric larynx, it should be straight, parallel. Interarytenoid axis and interglottic axis should be parallel. That is one. Second is look at the aryepiglottic fold. Is it a straight aryepiglottic fold or is it an angulated aryepiglottic fold? You start from the point of attachment to the epiglottis, cuneiform cartilage, corniculate cartilage. You make a line. It is a straight line. So this is normal. And look, both sides it is normal. The epiglottis, the cuneiform cartilage, the corniculate cartilage. It's actually a straight. And you see that piriform fossa is normal. And of course, also you look how this is the angle of the aryepiglottic fold with the glottis. So it is somewhere around 45 degree. So this angle, if you draw an angle here, this angle is around 45 degrees. So the aryepiglottic fold is at 45 degree to the interglottic axis, and interarytenoid angle is parallel to the interglottic axis. And all aryepiglottic fold is straight. So I will repeat again. First of all, you look at the aryepiglottic fold. It is straight. So you take 3 points: attachment to the epiglottis, cuneiform cartilage, corniculate cartilage. It is straight, like here. Second is look at the angle it makes with the vocal cord, the glottic axis. It is roughly 45%, somewhere around 45 degree. Third is the interarytenoid angle. There is interarytenoid axis and interglottic axis. Usually it is parallel. So this is the normal phenomenon you get. Now we will see how some patients are different. I have kept here on the normal side. See that in the aryepiglottic fold is straight on both sides, parallel to the interarytenoid axis, and interglottic axis is parallel, and it is around 45 degree to the vocal cord. Piriform fossa is normal. Now this is a case of the upper one is a case of left vocal cord palsy. Left vocal cord palsy, and see the right is compensating. Now you see that aryepiglottic fold is terribly angulated. So this is the attached to the epiglottis. This is the cuneiform cartilage, and this is the corniculate cartilage. So it is a big angle instead of a very straight aryepiglottic. Here you can see on the paralyzed side is a straight thing. Here is attachment of the epiglottis, cuneiform cartilage, corniculate cartilage. But the compensating arytenoid is terribly bent. So what does that suggest? It suggests that the right side, the normal side, is overcorrecting or trying very hard to compensate for the voice. It may be bad. It may not be very good in the long term. So this is a sign. And also look at the angle it has made. Now interarytenoid axis is somewhere here. Interglottic axis here. So it is so much skewed. And aryepiglottic fold itself is so different. Same thing in vocal cord paresis. I told few signs. The arytenoid will get pulled to the normal side. Here also you get the same sign. So in addition, this is a left vocal cord paresis. So see that the arytenoid has crossed over the midline. What are the other findings? Look at the normal side. Epiglottis, Cuneiform cartilage, corniculate cartilage. So again, an angulated area epiglottic fold. So this suggests the normal vocal cord is trying to compensate. So this can be added as another sign in the diagnosis of vocal cord paresis. So in vocal cord paresis, the normal side area epiglottic fold will become angulated, while on the paralyzed side is straight. See that? Take the epiglottis connection, cuneiform connection, corniculate. It is a straight thing. So when one vocal cord is overcompensating or medializing, the aryepiglottic fold will become bent rather than straight. Here again, you can see the angle between the arytenoid and angle between the glottis is skewed. So this is a pathology. We will see sometimes it happen even in normal. Now, this is a normal person. Actually, she is the voice trainer. Vocal, she is a very good qualified singer and a voice trainer in my group. Her voice is perfect. But when I did the scopy, sometimes you can see that in normal low pitch, you can see that the aryepiglottic fold is very straight here, both sides. But when she is singing high pitch, you can see that there is some bending of the aryepiglottic fold on the right side. She doesn't have any complaint, but probably it suggests that our larynx is never symmetrical. We actually do, I don't know which side, why is it related to your dominant hemisphere, I don't know. So when she's singing for a higher pitch, you can see the left aryepiglottic fold remains very, very straight, but the right start bending. So when you see the bending, it suggests that that vocal cord is trying to become more and more medial. It may be a compensation of a pathology like a vocal cord palsy when it is very useful in diagnosis, or it may be in a normal phenomenon. So that is why you see normal people overriding arytenoid. That is why people tell that if you don't have a symptom and you find overriding arytenoid, you call it as a benign overriding arytenoid. We don't know it. Now, the third is angle. So, I told the angle between the glottis and the aryepiglottic fold is somewhere around 45 degrees. Here, you can see that. But somebody is overcompensating. This, especially people who develop vocal nodule and ventricular band, they will actually push the aryepiglottic fold, the arytenoid medially, so that it becomes more transverse. So, the angle has become much wider than 45%. Look at the angle between the interglottic and the aryepiglottic fold. The angle is actually becoming bigger and bigger. So this also suggests that. So many times you will think that the patient is absolutely normal. Patient may come with a complaint and the only finding may be this. This may be the beginning of a vocal nodule, or it may be the beginning of a ventricular. But in both these conditions, I have seen this finding. They start more and more adducting, more and more medializing the vocal process of the arytenoid. That can happen. Now, another important finding is that you can see that ideally, symmetrically, it should be corniculate to corniculate and cuneiform to cuneiform. Actually, cuneiform shouldn't be meeting. They form a V shape here, but they are close to each other. And the arytenoid, the corniculate will meet each other. But see, in some cases, you get the other thing. Here, you can see the cuneiform on the left side is actually meeting the corniculate on the right side, and the cuneiform on the left side, right side is far more anterior. So this happens again when there is an overreduction. You can see that overreduction of the arytenoid will cause a rather asymmetrical closure of the arytenoid rather than cuneiform to corniculate to corniculate. You get a corniculate on the affected side to the cuneiform on the normal side. Again, you can see that picture here. The cuneiform on the right side is far away, while cuneiform on the left side is meeting the corniculate. So ideally, it should be something like that. The corniculate should meet each other. Cuneiform should come close to each other, but don't touch. So this is not a normal way of closure. So that is why I told in the beginning. Actually, there is not a real definition of how the normal phonatory behavior should be done. So I have looked into vocal process, granuloma, and all these things. Look here again. The patient asks, why we really don't know why vocal process granuloma occur on one side. We don't know why vocal cord polypo happen on one right side and in some other case left side. We don't know why vocal nodules are asymmetric on one side. It is bigger and smaller, maybe all because of the unusual adduction pattern. Look at this case. He has got a vocal process granuloma on the left. When it is abducted, they look all right. But when you adduct, when the patient is adducting, you can see that both aryepiglottic fold become bent. That means there is lot of medialization on the arytenoid level. And if you look carefully, you can see it is more on the left side. You can see that the angle here, the piriform fossa is much bigger on the left side. That means this arytenoid is closing too far in. That is why this become more transverse and the piriform fossa become smaller. So that may be the reason. If there is an overriding or overacting, over-medializing arytenoid, it may be the other arytenoid is developing vocal process granuloma. We don't know, but this is not normal. Vocal nodule, you can get again hyperreduction. Watch a child. See that the aryepiglottic fold is bent, and see that on the same the corniculate cartilage. Sorry, the cuneiform cartilage has gone too far inside. Again, there is an angulated aryepiglottic fold on the left side, while on the right side is straight. You can see the epiglottis, cuneiform cartilage, corniculate cartilage. That is straight. But on the left side, it is bent. He didn't have any other complaint. Only thing is that vocal nodule. So it probably suggests that there is over-medialization. The habit varies. So we are going to understand the physiology of vocal cord movement better and better in the days to come. And invariably in all adductor spasmodic dysphonia, this bend of the aryepiglottic fold is too much. That makes sense. It is bilateral. You can see that both arytenoids at the level of the you can see that is the cuneiform cartilage and the corniculate cartilage. So again, a bent aryepiglottic fold, this is not normal. We have seen that in a normal case it will be straight. So over adduction definitely brings this picture, this sign into the picture. So we don't know whether that actually decides the unilaterality of the disease or it may be the cause itself. It needs a lot of other studies. Again, I have seen that in most of the vocal cord polyps, it is actually on the less tense side. Here again, you can see that the right aryepiglottic fold is bent here. The left is fairly straight, and the vocal cord polyp has happened on the left side. This needs further study. I'm not very sure about, but what I am sure about is that arytenoids play a major role. And till now, our teaching has been everybody, including myself. I always, the moment I start doing scopy, I was so keen on looking the anterior commisure. I wanted to see the vocal cord. I never paid any great attention to the arytenoid. That shouldn't be the case. In functional voice disorder, when the vocal cord is not meeting properly, arytenoid can give you lots of sight. So never go too close straight away. Get a bird's eye view so that you can see the entire arytenoid glottis complex, and you look into these details in a very systematic fashion. You can get many points. So I want to conclude this talk with my most favorite slide. Many times I put this slide of Sherlock Holmes. He say that it is, one of his quote is that pay major attention to minor details and minor attention to major details. Why? Because there is a huge vocal cord polyp. You don't require a very keen eye. It will look at you. Even if you don't look at the lesion will look at you. But suppose there is a very small lesion like a sulcus or a overriding arytenoid, unless you are trained for that and unless you look for it, you are not going to get it. So always pay major attention to minor detail. I'm sure that more and more findings will come because larynx is such a dynamic, such a complex organ, so much of movement. Nobody even now really don't know why the arytenoid moves so differently. If it was very straightforward, all unilateral vocal cord palsy should have had an excellent treatment result with the thyroplasty and the rotation. That doesn't happen. So there are lots and lots of things we need to understand about the physiology of the vocal cord, especially the cricoarytenoid joint. So start to train yourself, looking at, don't just look at the lesion alone. Look at the larynx on in a holistic view. You should understand what is the arytenoid doing, how is the vocal cord moving, what is the right side moving, what is the left side moving. I think you yourself will become a big contributor to the laryngoid. Thank you.
Thank you, sir. That was very good presentation. There are few questions I would like to tell on behalf of audience. One is by Dr. Bharati ma'am regarding the KTP laser for vascular ectasia.
Yeah.
What is your opinion? Whether we can use KTP laser for vascular ectasia?
Fine. Yeah, right. You can use it. The only problem is that the KTP is quite a powerful laser. So unless it is actually going to hit the medial margin of the vocal cord, doesn't have any problem. You can do that. Now there is a much better laser like the blue dye laser for the vascular lesion. But if the user is very experienced, how to control the laser, how to control the power, and as long as you don't touch the medial margin of the vibrating margin of the vocal cord with the KTP laser, it is fine, no problem.
And one more question from Bharati ma'am. Is the arytenoid and cricoarytenoid joint which are important?
I didn't get the question. What is the question?
This question is not full, sir. Question is not. Another question is, how long? This is from Dr. Murthy from Hyderabad. How long we need to wait for intervention for vocal cord palsy in adults as well as in pediatric patients for both unilateral and bilateral?
Tell me again.
How long we need to wait for intervention for vocal cord palsy, both unilateral and bilateral in adults and pediatric patients?
Okay. So 4 sessions. Okay. So we'll start with the bilateral vocal cord palsy. That's a big problem. So in an adult, bilateral vocal cord palsy. So usually you know that whether it is going to recover or not sometimes, because the thyroid surgeon knows that the nerve is intact, it might recover. So the aim then is to secure an airway, right? Patient shouldn't actually choke to death. So any bilateral cord palsy, if the airway is good enough, we can leave it alone. But if the airway is not good enough, we have to secure the airway. So securing the airway is either by doing a tracheostomy, which patient may not be very comfortable. Then of course you can do a temporary procedure like codopexy. That is what I will generally do. So I will assess the glottic space. If the glottic space is reasonably okay, I will just put him under rest and nothing else, hoping that it will recover. But if it doesn't recover, if the airway is not adequate, then I have to secure the airway. So tracheostomy is an option till that recover. But if patient doesn't want, I can actually go for a suture codopexy. Then the permanent procedure, depending on if it is 6 months later, there is no recovery, you have to do a definitive procedure. There are many procedures. I think the most universally done is Kashima's posterior codotomy. There are a lot of other operations. I also now do the selective reinnervation, but I am in the early stage. Now, in a child, usually you don't do Kashima's operation because that is a destructive procedure. So I will actually do an endoscopic arytenoidectomy with a suture codopexy or a codoplasty. If it is very young child, I will still do tracheotomy and get the unilateral vocal cord palsy. The standard treatment would have been in 6 months' time. If there is no improvement, you go, and if the voice therapy is not bringing on good voice, you go for the surgery. You can actually do injection laryngoplasty. You can do thyroplasty. But there is definitely a change in paradigm. Right now, the concept is that in unilateral vocal cord palsy, you actually intervene straight away. Means you can do an injection laryngoplasty, which is an outpatient procedure. Why you should do is that one, most importantly, patient can have got an immediate voice. Second, more important is that if you are not doing a injection laryngoplasty and leaving the patient for 6 months, patient might recover very bad compensation, like the arytenoid I showed. It becomes very skewed. Then, instead of a thyroplasty, patient may also require a thyroplasty plus a far more complicated arytenoid rotation. So the current concept is that do injections with laryngoplasty straight away. That's an outpatient procedure. So that will work for 6 months. If it recovers in 6 months, great. If it doesn't recover, you need only smaller intervention. Of course, not every center you can do that. In a young child, the recovery chance is longer. In adult, if the vocal cord doesn't recover in 6 months, chance of recovery is not very great. But in children, it can go up to 4 years. So you will not do actually a thyroplasty in a young child, obvious reason, because the larynx is growing, you can't do it under local anesthesia. So if in a unilateral cord pulse, you can either do the injection laryngoplasty, you may have to do it again and again. If it is permanent, say at the age of 4 years, unilateral cord pulse is permanent, then the treatment is non-selective reinnervation. It's a very simple surgery. It has got excellent result. What you do is you take ansa cervicals on the other side and anastomose to the distal end of the recurrent laryngeal.
Okay. Okay, sir. Another question is from Dr. Sanjeev Mohanty regarding treatment for bilateral superior laryngeal nerve paralysis.
Bilateral superior laryngeal nerve palsy, again depending upon the cause. If it is a thyroidectomy, you have to check with the surgeon whether if the nerve was intact. If it recovered, fine. If it is not recovering, then you may have to think about it. Most of the time, unless he is a voice professional, this patient can actually be treated with voice therapy alone. They will have some problem with their voice, like voice fatigue and difficulty in high pitch, but usually manageable with the voice therapy. But if patient is not improving and patient is a professional, then that's a much difficult issue. You can actually do bilateral type of thyroplasty. That's a cricothyroid approximation that will improve the voice, but it is not going to make voice perfectly normal. And unlike selective reinnervation with the recurrent laryngeal nerve, results with superior laryngeal nerve reinnervation has been not very great. So don't do reinnervation. In a very resistant case, go for bilateral type of thyroplasty.
Okay, sir. One more question by Dr. Rahman. Can we remove foreign body with flexible laryngoscopy?
Foreign body from the flexible laryngoscopy, answer is yes and no, depending upon the situation, where, how old, how operate is the patient, that is all. You cannot do a big foreign body, but you can.
Okay. Another thing is by Dr. Rajesh. Is vocal tremor associated with Parkinson's disease?
No, usually not. The vocal tremor is usually associated with the essential tremor, the neurological tremor, not the Parkinson tremor. Parkinson tremor, that it is the rest tremor,
okay,
not the intention tremor. Right? It is a cerebellar tremor, which is the intention tremor. So Parkinsonism tremor and the vocal tremor, I haven't seen together.
Okay. And another question by Dr. Udbhav. How to differentiate between muscle tension dysphonia and pharyngeal squeeze?
Pharyngeal squeeze actually is a muscle tension dysphonia, but unfortunately not classified as of now. It is very simple. In pharyngeal dysphonia, squeeze, what happens is that the lateral wall of the thyropharyngeus or the lateral wall of the pyrethrum fossa come and meet the medial wall of the pyrethrum fossa. That is highly epiglottic. Okay. This usually doesn't happen in speaking voice. It happens only in singing voice.
Okay. And another question by Dr. Sonali. Diagnosis and management of leukoplekic lesions.
What lesion?
Leukoplekic lesions. Leukoplekia.
Leukoplekia. Okay. Leukoplekia, you have to exercise in toto and get for the biopsy. So if you have got the carbon dioxide, then the carbon dioxide laser, that is the treatment. Endoscopically, exercise in toto, check for the frozen section, check for the margins are clear, then treat accordingly. You may have to tell that it may come back. That's the problem. And if there is a predisposing condition, a causative agent like use of tobacco and all, patient has to be inspected to stop that.
Another question, actually, I think you have already discussed. How do we clinically differentiate paresis from paralysis?
Yeah, but I think, but that is important that the paresis is subtle. So if patient present with a recent onset of hoarseness or breathiness, you see the patient, you do the scopy. What will happen is that there will be a phonatory gap. and on the affected arytenoid, mind you, the affected arytenoid will actually cross over the midline to the other side, because this is because of the pull of the bilaterally innervated interarytenoid. Interarytenoid is between two arytenoid and right and left.
Yes.
Suppose the left is pareized, so what will happen? Left arytenoid is weak. So the interarytenoid with a strong foothold on the right arytenoid will pull the left arytenoid towards the right arytenoid. So
Yes,
the
sir.
pareized arytenoid will cross over the midline.
Okay.
And on the side of pareisis, the ventricle will be
Deeper.
deeper.
Yes, sir. And another question from Dr. Subhash. Can we predict while doing flexible laryngoscopy the possible exposure during the actual surgery? Are there any predictors so that
Possible what?
any predictors for getting the good exposure during surgery?
Okay. Flexible laryngoscopy is unlikely to tell much. Even the clinical examination is generally okay, and the rigid scopy will tell you, because if we can do a reasonably good rigid scopy, that means the larynx is not unfavorable.
Okay.
Very high anterior larynx is going to be very difficult. In a flexible laryngoscopy, you will overlook it because you are actually going through the nose and the oropharynx, so you might not look into it at all. A rigid laryngoscopy, you are doing a rigid 90-degree or a 70-degree scopy.
Yes.
You have got great difficulty in visualizing, then you know that this is going to be difficult. But there are a lot of clinical parameters. One is the, that the Mallampati is 18. So a Mallampati 3 is going to be very difficult usually. A proclining upper teeth will be bad. Retruding chin will be very bad. If you do the IL, and I think there is a classification called Cormack-Lehane. If you do the IL, normally if you can see the entire vocal cord up to the anterior commission, that is an easy case. Suppose you can see only arytenoid or the posterior most part of the vocal cord, then that is going to be a very difficult case. Actually, there are a lot of predictors.
Yes, sir. And another question from same Dr. Subhash. What is your opinion on high-speed imaging? Is it useful in clinical practice? High-speed imaging.
Camera, I mean laryngoscopy. Yeah.
Yes, sir.
I don't have any experience, but you know the problem. High-speed camera is actually a wonderful thing. Whatever I have seen, it is a wonderful thing. Because remember, when I talked about the vocal cord cyst, I told that there won't be any mucosal wave over the vocal cord cyst, because stroboscopy is an optical illusion and it takes the reference point as the vocal cord vibration. So only frequency which is similar to vocal cord will be seen vibrating. High-speed camera doesn't have any problem. So it will show the vibration of vocal cord, ventricular band, growth, cyst, polyp, everything. So it's a fascinating, fantastic equipment. The problem is that it is 8,000 frames per second.
Yes,
so what will happen? If you want to watch 1 minute, when you play it slow motion, it will finish your hard disk. And it will take more than hours to see the entire 1 minute study. So that is the technical issue. Otherwise, it is a fantastic equipment.
Yes, sir. And one more question from Dr. Lee Joy. He is telling what is better to do in this COVID epidemic, whether to use flexible scope or whether to use rigid laryngoscope, as both procedures are involved with producing aerosols.
Yeah, right. So I will put it another way, and that is what we practice. In a larynx patient, any patient, you have to take detailed history, where they are coming from, all those things, COVID thing, I'm not going to that. Now, you have got three kinds of cases: the voice cases, the swallowing cases, the airway cases. Okay, voice cases take a detailed history. If it is unlikely to be, there is no chance of malignancy, you can actually postpone the scopy for the time being. Swallowing, you are not going to do the fees as of now, because it creates lot of fees, produce lot of aerosol generation. Airway, of course, you have to do it. Now, I generally prefer to do the flexible laryngoscopy than the rigid scope, because patient may cough, the throat may be very sensitive. So what you do is you take all precaution, your own precaution and patient's precaution. Patient should be given a mask. So patient should put a mask on and put a small hole in the nasal cavity region and pass the flexible laryngoscope through that hole. So even if patient is sneezing or coughing, that is partly prevented. So keep the mask there. Okay, and don't use spray. You need to just put a xylocaine jelly over it and then go to the scope.
Yes, sir. There are lot many questions more. One is from Dr. Jasmine Joy. She's
Yeah,
asking how to manage a case of amyloidosis, treatment and management.
good thing about amyloidosis is that you can actually exercise. And very rarely it actually recurs. In my 21 cases, I had only one case of I had to go again and do that. Usually, it's laryngeal amyloidosis, a much benign condition. You debulk it generally okay. If it is bilateral, do it as a stage procedure. You can actually excise it in 2 stages because if you excise all circumferentially, it may result in stenosis. As of now, I prefer to use the goblet to excise endoscopically.
Okay. Yes, sir. And one is from Dr. Vinay Gandhi. Any particular findings of COVID laryngitis? Anything have you seen recently?
I haven't seen anything, but I think most of you might have seen a talk by Dr. Martin Birchall from UK, and of course, Kishore Sandhu was talking last week. There are 2-3 things which we are not very sure about. Of course, it produces a laryngotracheitis, and Kishore was telling that there is some amount of petechial hemorrhages too. But the problem here is because of the fear of aerosol generation, and it is actually being controlled by the anesthetist. What they did is that they always use the bigger size endotracheal tube.
Yes.
So, bigger size endotracheal tube, keeping longer time, they are prolonging tracheostomy, right?
Yes,
and they are inflating the cup, and they are not deflating the cup every 6 hours. So, it is a recipe for a disaster, right? So, naturally for a way, but no other way. So, I am sure that in COVID countries, in 6 to 9 months' time, there will be a lot of laryngotracheal stenosis. So what Martin Birchall has told that when he pulled out we tried to take out sorry.
Sir, you are audible, sir. You can.
Yeah. When you are when he was trying to take out, he was almost like stuck to the trachea. So there is a lot of granulation tissue, all kind of damage. Otherwise, I don't have any personal experience, and I hope that I don't get a COVID patient to home.
Sir, this is my question.
Yeah.
So, what is your current treatment for sulcus vocalis?
It is one of the most difficult condition in phonosurgery.
Yes, sir.
So it's not an easy condition. The problem is that there is a scar in the medial margin. Okay. There is vocal cord atrophy, that means a phonatory gap. There is lack of pliability in the medial margin of the vocal cord, and there is secondary muscle tension dysfunction. Okay?
Yes, sir.
So you have to correct all these things. Phonatory gap is easily corrected. You can actually do a thyroplasty, bilateral thyroplasty, or injection laryngoplasty. That is no big deal.
Yes, sir.
Regarding the scar, or absent or a deficient Raynaud's space, the nearest thing to a Raynaud's space right now available is fat.
Fat.
So if you can inject fat into the Raynaud's space and get it, that is good enough.
Okay.
Now, making the medial margin of the vocal cord pliable, as of now, we don't have any treatment. It remains always stiff.
Okay.
So ideally, what you should be doing is that you should excise the entire scarred mucosa, fill that Raynaud's space with fat, and then approximate the vocal cord mucosa thoroughly. This is humanly impossible as of now endoscopically.
Okay.
That's the problem. That's the problem why we are not getting the result.
Yes,
and it's not justified to do a laryngo fissure, open up the entire thing and do this surgery. We don't know.
Not
so
possible.
Maybe the technology will become bigger. You may be able to suture and undermine the mucosa, so that time your result may be better. So if the mucosa is scarred, the results are not great. So all the surgery right now only improve the sulcus vocalis. It doesn't make the sulcus voice normal. Of course, you have to correct the secondary muscle tension dysphonia with voice therapy. So my treatment policy as of now is that a young patient, I will first reconstruct the Raynaud's space with the fat.
Sir, anything with office-based steroid injections into the Raynaud's space? Will it improve?
I don't do that because the steroid is not going to do. It may do a scar lysis, but it will not regenerate the Raynaud's space. You need a big full Raynaud's space for the voice.
Yeah.
Okay. So it's an index steroid, but that may create maximum scar lysis. So what I do is that I reconstruct the range space right now, put him in intensive voice therapy for 6 months. Then at the end of 6 months, when there is no more increase in the mucosal vein, if there is a phonatory gap, I will go for the second stage and do a thyroplasty to cross off it.
Yes. Yes, sir. Thank you, sir.
Thank you.
And one more question is, what is the treatment of post-radiotherapy persistent edema of larynx?
Oh, it's a very, very difficult condition. If that happens and the patient has got a strident, I think most of the surgery to open up the airway will be a catastrophe. That will actually cause more aspiration. So if there is persistent edema, I will simply do tracheostomy and hope that it will recover. I will not do a Kashima. I will not do any of that procedure. They all create very bad results.